Okay, good morning, good afternoon, and good evening, everyone. Welcome to this SMRA webinar on carotid plaque imaging. My name is Zhaoyang Fan, and I'm from the University of Southern California. I'm joined by my co-moderator, Dr. Yibin from City-Sinai Medical Center.
Hi, everyone.
And today, we are delighted to bring together 4 leading experts who are at the forefront of both clinical practice and technical innovation in this important and evolving field. I'm confident that their insights will help us better understand the latest advances, ongoing challenges, and future opportunities in carotid plaque imaging. So each speaker will give a 15-minute presentation, and we will reserve about 10 minutes at the end for Q&A. So during that session, the audience can just raise hand and we can let you speak. So thank you again for joining us. Now let's get started. So our first speaker, Dr. Luca Saba, will talk about the PLAQUE RADS for carotid atherosclerotic disease risk stratification. And Dr. Saba is a neuroradiologist in the University of Cagliari, Italy. His research focuses on atherosclerosis and the relationship between plaque vulnerability and ischemic stroke. Dr. Saba, please.
Thank you so much for this kind of introduction. It's a pleasure to be here to give this talk, PLAQUE RADS for carotid atherosclerotic disease stratification. And in particular, I'm glad to be together some of my friends, Xihai, Kevin DeMarco, and Chun Yuan. So I think that will be a very interesting session. Before to start and to speak about the risk stratification, I think it's important to share some basic information. So I will speak about, for a couple of minutes, about the change of pathology, of stroke pathology. I will touch the Jesus problem and a few minutes about the degree of stenosis. And then I will move to the next section. Let's start from the change of atherosclerotic pathology, because we know that there is a change in the last 40 years. If you look at the papers published in the last 10 years, we know very well that there is a reduction in the stroke prevalence, in particular in Europe and Asia. If you look at the death rate from stroke in 1980, you can see this map. We are looking at the death rate from stroke for 100,000 people. This is 1980. But if you look what happens in 2021, this is the difference. So a significant reduction in the stroke rate. And this reduction is interesting, is not present for younger people, but is very strong for people with 65 years old or older. Another important point is that there is a difference for the stroke risk factor. What happened? Compared to the 80s, there is a significant reduction in smoke. There is a same values for hypertension and an increase for diabetes. And this is important because reduction or change in prevalence of hypertension and diabetes change the plaque biology and characteristics. I will not move in depth on the concept, but it's important to keep this in mind because we should talk about risk stratification, and we must be fully aware about the prevalence of the disease that has changed completely compared to the past. And why should we treat patients according to 40 years old indication in the risk of stroke if nowadays is much lower? The second point is the ASUS problem, the embolic stroke of undetermined source. It's a quite prevalent condition when we speak about ischemic stroke. It's roughly 24–25%. And there is a problem because we should consider a patient with a specific cause according to guidelines. And if we consider carotid pathology, we cannot consider a cause of stroke a carotid that do not have a stenosis of 70% or more. What does it mean? If you look at this image, you're looking the case of a gentleman, 71 years old, and a nascent stenosis of 32%. But if you look at the plaque, you can see very well the intraplaque hemorrhage. The intraplaque hemorrhage patients with stenosis of 32%. Okay, according to the current guidelines, you cannot consider these patients with this stroke attributed to carotid artery disease. So there is a big problem on this point. Gradually, this paradigm is changing. I want to share a landmark paper published in 2019 by Umar Kamel Group in German Neurology, where firstly he introduced the concept of a non-stenotic atherosclerotic plaque as caused for ASU stroke. And this concept was also introduced and incorporated in the guidelines published by European Society of Cardiology in 2024. So the concept that carotid atherosclerosis, even without the degree of stenosis, can cause a stroke now is accepted as a concept. But we said the degree of stenosis, without degree of stenosis, but why we considered the degree of stenosis as the key parameter? Well, the degree of stenosis is considered the biomarker to stratify the degree of a stroke for a simple reason, because it was used in the NASH trial and in the X trial in the 80s. The NASH trial showed the benefit of revascularization in patients with a degree of stenosis of more than 70%. So it was the biomarker to select the therapy, and you can see the impact in patients without revascularization and with revascularization. From that point, you should consider that in the 80s and 90s, the only approach that we could have to explore in vivo carotid arteries was angiography. And with angiography, the only information we could obtain was related to the morphology. So no information about the plaque, but only morphology. From that point, all guidelines have considered the degree of stenosis and substantially only the degree of stenosis, the gatekeeper for the selection of the therapeutical strategy. I'm showing you European guidelines of 2018, but it's the same if you look of the American Heart Association of the American Academy of Neurology. There is a point, degree of stenosis, that stratify the therapeutical choice. But we know very well that the degree of stenosis has a huge problem. There is no consensus in the measurement, and this is well demonstrated in the literature. And we know also that radiologists do frequently error. Look at this letter from Alan Fox, that is the lead investigator of the NASH study, for example. There is also another point that is a conceptual point. We should keep in mind that the degree of stenosis is an indirect parameter. So it is the effect of the carotid plaque. If you look at this example, in this case, you are looking at the common carotid artery, internal carotid artery, and here is the plaque. And if you apply the NASH stenosis, the degree of stenosis is 45%. So according to the NASH, this is a non-stenotic plaque. However, you can see that plaque morphology is significant, regardless of the stenosis degree. And you should remember also the lessons from pathologists. If you check the literature and look at those papers published in 1979, look at the title, The Carotid Bifurcation, Pathological Findings Associated with Cerebral Ischemia. And they introduced the concept that most of these patients with the stroke had intraplaque hemorrhage. So it was a very well-known concept by pathologists. But what was the problem? That pathologists needed to see the plaque. So it cannot, and the medicine and the technology could not obtain this kind of information in vivo. But currently we have the technology to produce this kind of information in vivo and not requiring the ex vivo assessment. This is a landmark paper published in 2019 by Andreas Schindler that showed, for example, that intraplaque hemorrhage, independently from the degree of stenosis, is the stronger predictor of ischemic event in both symptomatic and asymptomatic patients. So we know that there are a lot of features of vulnerability. These are the 9 most important features: ulceration, intraplaque hemorrhage, the status of the fibrous cap, presence of neovascularization, status and composition of the calcium, the remodeling of the plaque, inflammation, volume of the plaque, and the volume of the subcomponents, and the plaque thickness. But what is the problem? That all these variables are disaggregated we do not know the exact value compared to the other ones. And sometimes it's easier to detect one feature with a single imaging technique and another one with another imaging technique. So the plaque RADS study was built in order to try to solve this problem, to create a level of stroke risk according to a matrix, RADS 1, 2, 3, 4, and to build a model that could be used by ultrasound, CT, and the MRI. I do not explain the plaque RADS model. I think that you already use. I want to share the basic assessment. So plaque RADS 1 means that there is no a significant plaque. Plaque RADS 2, low risk, a plaque with a thickness of less than 3 millimeters or absence of features of vulnerability, and the class 3 and 4, where you can see features of vulnerability. So presence of ulceration, intraplaque hemorrhage, rupture of the fibrous cap, and the 4C, the presence of floating thrombus. These features can be easily detected by one technology or by another one technology. For example, calcium can be very well studied with CT. With magnetic resonance, we study very well the intraplaque hemorrhage, the status of the fibrous cap. Currently, with the introduction of the photon counting, maybe something will change, but we are currently studying the impact of the photon counting in the plaque RADS assessment. And currently, for what we know from the literature and our experience, magnetic resonance is the best modality to exactly assess the plaque RADS in carotid, because it can identify the class 4B very well, 3B very well. So the status of the fibrous cap, the 4B, the presence of the ruptured fibrous cap, and the status of the 4A, the presence of intraplaque hemorrhage. So currently, magnetic resonance is the top choice. There are some open points. So how the plaque RADS can be used by multiple readers in terms of inter and intra-observer reproducibility, the inter-technique reproducibility, so between ultrasound, CT, and the MRI, and in particular, and this is the key point, the application in terms of risk stratification. Regarding the inter-observer reproducibility, there is a paper published on a JNR in April 2025 on CTA that showed that the plaque RADS works quite well. The Cohen kappa value are roughly about 0.8, and we tested also different level of experience. So the best performance were obtained by the expert, lower by the beginner, but there is a learning curve. So also the less expert, the beginner, can increase the potentiality in interpreting with the plaque RADS by checking multiple exams. Roughly 500 exams is the adequate number to interpret correctly with the plaque RADS. The other important point is the application of the plaque RADS in terms of risk stratification. When we speak about risk stratification, we should consider primary stroke and recurrent stroke, and we should keep in mind that most studies focus on symptomatic patients to track recurrent stroke, but the majority of ischemic stroke are actually primary stroke, meaning that they occur in patients who have never previously experienced a cerebrovascular event. So we study most recurrent, but most of the stroke are primary, and this is an important point. Another point is that the plaque RADS is explored in some papers as a mixed model. So how can change the stratification by considering also the degree of stenosis, or by using other parameters together with the plaque RADS, for example, the PFT, so the perivascular fat density. I want to show you some papers that show the preliminary results. The first one is the paper from Xihai Zhao, published in September 2024. That is a paper with a big population, 1,378 patients, and the follow-up is a retrospective paper where they studied a significant population for roughly 6 years, and they found these results for ischemic stroke, so primary stroke. You can see the effect of the plaque RADS independently of the degree of stenosis, and This paper demonstrated the potentiality in terms of progression and the risk stratification for the main classes and also for the subclasses 3A, 3B, 3C, 4A, 4B, 4C. And the same impact is also present for the recurrent stroke. You can see the secondary stroke for the main classes and also in these cases for the subclasses. And in this paper is also explored the effect of restratification by considering the degree of stenosis. So if you are considering a mild stenosis, so below 50%, the class 1, 2 is the blue line, whereas the class 3, 4 is the green line for primary and recurrent stroke. So it's important, the potentiality of restratification in mild stenosis. Another paper was published in April 2025 and was performed on 433 patients. And also in this case, the difference in terms of stratification is demonstrated. It's interesting because the plaque RADS class increased in advanced age and with smoking history. So it seems to be sensible also to specific fingerprint in terms of biology. There is no difference in hypertension, but in smoking history. And obviously it's demonstrated the stratification in terms of cerebrovascular events. This is a very beautiful image, in my opinion. You see here the same level of stenosis degree, a mild stenosis in left side and right side, but in one case there is a 4A class, so an intraplaque hemorrhage, the patient is symptomatic, and so it's important. Another paper was published in March and gained the cover of stroke and was based only on patients with ASUS condition, so undeterminate cause of stroke. And also in this case, the plaque RADS show to be capable to stratify the risk in the population of ASUS. So this is the first evidence that we can use the plaque RADS to detect and to reclassify patients with ASUS. Another paper was published a couple of days ago and used the plaque RADS and the assessment of the perivascular fat disease. Was published in May 29 Academic Radiology. The population is roughly 300 patients. And you see that also in this case, the potentiality independent of the degree of stenosis of the different class of plaque RADS is demonstrated. You see here class 1, 2, 3, and 4. But the authors used also the perivascular fat disease by creating another model. So plaque RADS 3 and 4 and PFT below minus 74 Hounsfield unit for high risk and class 1, 2, and the opposite in terms of fat density for the low risk. And you can see here the effect of restratification. So the plaque RADS can be also useful for the restratification of the risk. This is a beautiful image that shows the restratification, and in practice, by applying these models, we are reclassifying ASUS patients who previously would have experienced an event that could not be attributed to the carotid artery as the cause, whereas now the carotid can be recognized as the underlying cause. In conclusion, plaque RADS was introduced approximately a year and a half ago, and an increased number of studies are now emerging that use it for restratification. While the data still need to be consolidated with larger patient cohort, the preliminary results, now involving over 2,500 patients, already indicate that plaque RADS class really must stratify the risk, including its subcategories. Its performance in distinguishing between primary and recurrent stroke still needs to be further explored, and it remains to be checked whether combined model can provide ever more refined predicted performance. Thank you for your attention, and thanks.
Okay, thank you, Dr. Saba, for this very informative talk. So just reminder again, we are going to leave all the questions to the end of this session. Okay, so now let's move on to the second talk. So our second speaker, Dr. Xihai Zhao, will be talking about the quantitative imaging applications and the associations with patient symptoms. So Dr. Zhao is a Vice Dean of the School of Biomedical Engineering, Tsinghua University. He served as the president of SMRA during 2022 and to 2023. Dr. Zhao's research focuses on technical development and the clinical application of MR vascular imaging, particularly vessel wall imaging for plaque assessment. Dr. Zhao, please.
Can you hear me? Yeah.
Yes.
Yeah. Okay. Thank you for your invitation and introduction. It's my great pleasure to discuss quantitative imaging techniques and potential clinical values. This is my outline. And as we know that carotid plaque rupture is one of the major leading causes of ischemic stroke, accounting for 18 to 25% of cerebrovascular events. On histology, the vulnerable plaques showed large lipid core, thin cap, intraplaque hemorrhage, perhaps cap rupture, inflammation, or neovasculature. However, the vulnerable plaques will be inhomogeneous on histology regardless of their stenosis level. For example, here, the 3 cases show the same stenosis level but different vulnerability. Here, this is intraplaque hemorrhage, unstable, calcium nodule, unstable, and this is a fibrous plaque, stable. So currently we used the modified HA classification for MRI to classify carotid plaques in different types using the multi-contrast visual imaging techniques. However, this technique can only evaluate the remarkable plaque compositions. For those tiny plaque compositions, it is very challenging to assess those components. This is one slice of the carotid plaque specimen after CEA. We can find that this plaque is very inhomogeneous, and we can find a larger plaque components here and here, but we can also find some tiny plaque compositions. So it is suggested to refine the plaque classification system, especially to stratify with for those vulnerable plaques with inhomogeneous plaque composition, especially for those the smaller size of plaque components using the quantitative imaging techniques. Here, firstly, I'd like to introduce the single parametric imaging techniques. Investigators proposed golden angle radio case-based sampling imaging techniques called GoSNAP to acquire the T1 mapping. Using this technique, actually, we can identify and quantify the intraplaque hemorrhage because the hemorrhage will show a lower T1 value, a shorter T1 value here, and but here you can find in the right corner we can find some tiny intraplaque hemorrhage on the vessel wall here, but it is very challenging to identify these tiny intraplaque hemorrhage using multi-contrast imaging techniques. So actually, we validated this technique using histology. We find that in theory, T1 mapping can differentiate loose matrix, lipid-rich necrotic core, and the intraplaque hemorrhage based on the T1 values. However, it is still challenging because the spatial resolution issue. So we also find that there is moderate to excellent agreement between T1 mapping and histology in identifying and measuring intraplaque hemorrhage. So some investigators proposed multi-echo spin-echo imaging sequence to acquire T2 mapping. Actually, using this technique, we can identify and quantify lipid-rich necrotic core because lipid core will show shorter T2 value. Here in the right column, we can find that there is larger lipid cores, but we can also find smaller lipid cores. And for this tiny lipid cores, it is really challenging to evaluate this component using the multi-contrast imaging techniques. Some research group also validated this T1 mapping with histology. They find that there is excellent agreement between T2 mapping and histology in quantified lipid-rich necrotic core. And some researchers also use the technique to monitor the treatment effect of carotid plaques. They find that there is significant reduction in lipid core after starting treatment. For example, in this column, we can find that at the baseline, there is a small lipid core, but after treatment, the small lipid core disappear. So there is a research group, they developed T2 star mapping imaging technique. Actually, T2 star mapping is a very challenging technique because the signal to noise ratio is not so high. But this technique is very sensitive to identify or quantify the intraocular hemorrhage, especially for the old hemorrhage. So some researchers find that T2 star mapping can differentiate patients with or without clinical symptoms. The symptomatic patients will show lower T2 star values. And the Arthur star mapping is very similar to T2 star mapping. And some investigators develop the 4-point Dixon sequence to acquire the Arthur star map. And they use this technique to evaluate the intraplaque hemorrhage. And it's very interesting that the susceptibility imaging and QSM, this technique can be used to differentiate calcification and iron or old intraplaque hemorrhage. So, for example, the intraplaque hemorrhage will show the bright signal on QSM, but the calcification will show the hypointense on QSM. And interestingly, some investigator using this technique to detect the neurovasculatures in the plaque by injecting the USPIO, because this contrast agent will go into the new vasovasorum, and then we can detect them using the QSM, and we can also use this technique to differentiate from the calcifications. Some research groups also validate the QSM technique to in evaluating the intraplaque hemorrhage and calcification. So here and here. So finally, I think I want to point out the single parametric imaging technique is the diffusion weighted imaging. Investigators using 2D EPI sequence to acquire the images, but however, the image quality is not so good. SMRA is very low. Here we can find that the lipid core will show the lower ADC value. And this is another study validating this technique using histology. So Dr. Yibin here and colleagues develop 3D TSE imaging sequence to perform the diffusion weighted imaging and calculate the ADC value. Actually, this technique is very promising because the image quality is much better, and we can find that the ADC map is very clear, and the lipid-rich necrotic core can be delineated very well on the ADC map. So to enhance the imaging efficiency, actually investigators develop multi-parametric imaging techniques. For example, one research group proposed 3D multi-echo phase-sensitive inversion recovery imaging technique to acquire the T1 and T2 star mapping simultaneously. And this technique can be potentially used to identify the intraplaque hemorrhage classification as well as the lipid-rich necrotic core. And Dr. Huijun Chen's group proposed imaging sequence called the SIMPLE. And this technique will acquire the T1 and T2 maps simultaneously. And using this technique, we can both identify or quantify the intraplaque hemorrhage and the lipid-rich necrotic core. And there is an upgrade sequence named Simple Star from the same group. They use this technique to acquire the T1, T2, and T2 star maps simultaneously. And actually, this technique is very comprehensive, and the lipid-rich necrotic core and classification and intraplaque hemorrhage can be detected using this technique very easily. This is another example. Here we can find a lipid-rich necrotic core, shows very inhomogeneous T1 values, but lower T2 value and T2 star value. So our group developed imaging sequence called the schema. Actually, in using this schema, we perform the 5 dynamic scans to calculate the T1 and T2 and the T2 star maps on the vessel wall. Actually, we used the technique to differentiate to discriminate the symptomatic status in the patients with carotid plaque. So finally, this technique is a Q match from Dr. Yibin Xie and colleagues group. Actually, this technique is very promising, and because they just used a single scan to acquire double blood MRA, T1 map, and T2 map, and they can also generate T2 weighted and T1 weighted images. So clinical trial called DETECT utilize this technique to acquire the images in some patients. So here I'd like to thank Dr. Kevin DeMarco for sharing this slides with me. So finally, I'd like to summarize my talk. The quantitative visual imaging can be achieved by either single parametric or multi-parametric sequences. Many quantitative imaging techniques currently lack histological validation. The different quantitative imaging techniques can be used to in the different clinical needs, I think. For example, assessing the plaque vulnerability and monitoring treatment effect, etc. Finally, I think the usefulness of the clinical values of the quantitative imaging need to be largely validated in the clinical studies. Thank you very much.
Thank you, Dr. Zhao, for a great summary of quantitative imaging techniques. So now let me pass on to my co-moderator, Dr. Yibin Xie.
Thank you, Zhaoyang. Great talk, Xihai. And now it's my pleasure to introduce our next speaker, Dr. Kevin DeMarco. Dr. DeMarco earned his medical degree from St. Louis University and later completed his training in neuroradiology at UCSF. He has served on the U.S. Navy from 1982 to 1993. And his early research focused on non-invasive imaging of carotid stenosis using contrast-enhanced MRA, and later transitioned from the lumen imaging to direct imaging of the plaques. Recently, he's one of the co-PIs of a multi-center trial evaluating quantitative imaging on carotid plaque funded by NIH and VA grants. Dr. DeMarco is a collaborator of mine, and he's probably one of the most experienced readers on carotid imaging in the neuroradiology area. His talk title is Clinical Value of Carotid Plaque Multi-Contrast Conventional and Advanced Applications. Dr. DeMarco, the floor is yours.
Thank you very much for the introduction and also the opportunity to share with you some thoughts on the clinical value of carotid plaque imaging. I would like to acknowledge government research fundings, and this is my disclaimers. Before we go any further, and we've already heard an introduction about this, we need to talk about the elephant in the room. Almost all existing guidelines use stenosis alone to recommend treatment. So why are we here? Should we just go home? And we've heard really compelling cases. No. And the obvious answer is our clinicians are very smart and they know how to treat patients when there's no definitive randomized clinical trial. So we're here to educate ourselves, as we've heard today, and then subsequently our clinicians on how carotid plaque imaging can help them estimate the risk of future stroke. So I'm only going to want you to get 2 nuggets out of my talk today. Nugget 1. This is for the clinicians, obviously. Ask your clinicians how they use carotid plaque imaging to help treat their patients. That single question will lead to a very interesting conversation, I guarantee you. As we've heard already, the European Society is further ahead than many of the others. Vascular surgery and cardiology updated their guidelines to include that an endarterectomy is indicated in the presence of 1 or more imaging characteristics associated with high risk. So I will also take you through some of the literature that makes that point for you and for your clinicians, and the ways that potentially you could use that information to suggest changes in patient therapy. So what your clinician will typically do is they'll go to duplex ultrasound first, but if they have questions about the carotid stenosis, they'll order a CTA or MRA. And we can also start looking for plaque information on our routine clinical studies. And I'll illustrate that with this point. JR is a 65-year-old man admitted in March of 2014 with a non-STEMI, subsequently shown to have 3-vessel coronary artery disease, treated by endovascular treatment by the cardiologist. The vascular surgeon's duplex ultrasound showed right more than left carotid stenosis. Now, this patient, remember, was being evaluated and treated by cardiology vascular surgery and was definitely on optimal medical therapy. Despite that, in the vascular surgery clinic, they showed a clear progression in stenosis on the duplex ultrasound 2.5 years later, which then prompted them to order the CTA. So being good neuroradiologists, we measured the carotid stenosis. But here is the main take-home point, nugget 2. Don't leave money on the table. You can very clearly see a low attenuation plaque, clearly lower attenuation than sternocleidomastoid muscle. You don't need any fancy software. This is available to you every day you read a carotid CTA. Talk to your clinicians, nugget 1, to make sure they understand why you're saying that and that they want this information. Of course, the way I'm describing this, things didn't turn out so well. This patient subsequently a year later, with no change in medical therapy, went on, had fibrous cap rupture and had intraluminal thrombus, and of course an ipsilateral stroke. The left side that was all calcified didn't change. And so we can see anecdotally how progressive stenosis occurred despite optimal medical therapy, and a large necrotic core put the patient at risk. And as we've heard Dr. Saba describe, excellent depiction of this very powerful new technique of PLAQUE RADS, and the person progressed all the way to type 4C. So what is the literature that tells us that there's a better depiction of future risk and by identifying carotid plaque necrotic core than simple carotid stenosis alone? Many cases I could show you. I still love this now relatively old meta-analysis, 9 studies, almost 800 patients. The presence in the carotid core was associated with the risk of future stroke, or TIA, with a hazard ratio of 3, and there was no association with carotid stenosis. One of the challenges with CTA alone is that soft plaque that we were talking about with decreased attenuation. There's multiple issues that can affect it, with contrast enhancement, how you're obtaining the CT, the density of the calcifications that are frequently there. This has led multiple companies to develop new reconstruction algorithms to help decrease blurring and partial volume effect. And this is the results from one company. These slides lent to me by Andy Buckler. This is what we're typically used to seeing left internal carotid artery. Here's the residual lumen, dense calcifications. And this dark area right here, very comfortable, because I've read literally thousands of these, that is a dark necrotic core. But you can see after image restoration how much easier that is to see, and also the deep blurring from the calcification. Again, one of many software algorithms available for conventional CT, and it's been validated with histology in measuring the necrotic core. This then led other investigators to ask the question, okay, can this tool help us measure changes in necrotic core volume? So they asked what was the repeatability and reliability of carotid plaque morphology measurements. So they did this in 3 centers, 1 observer, a medical student, then did repeat measurements, and they were able to show very small change. They could detect very small changes in plaque volume and plaque composition, including necrotic core volume. So this gives us a really powerful tool to be able to say if things are getting better. Because of course, once you've got your clinicians changing medical therapy because you say there's a bad necrotic core, the next question is they're going to want to know, is it getting smaller? Just like when you have a lung cancer and you start therapy, you want to know if it gets smaller. Now, you know, those of you here will go, Kevin, you're fooling me. This is an MR, and that's because CT's new kid on the block. But we can see the necrotic core volume decreasing over time. There are multiple other studies, but this is still my favorite study, carotid plaque composition, because it showed us this temporal change. And most importantly for me as a clinician, talking to my clinicians, once you get to 3 years, you've pretty much got your major bang for your buck. And if you still see significant necrotic core volume, clinicians need to do something different. These images lent to me by Dr. Saba show us also the potential of photon counting CT. This is our usual CT reconstruction. You can just see the marked improvement, especially notice calcification. So that's a new thing coming to your shop soon. Now, this is the SMRA, so we should talk about MRA somewhere in this presentation. And of course, as we've already heard, intraplaque hemorrhage is the killer app. It is the thing that we can see really well, and it's really important in predicting plaque progression and new stroke. We take advantage that the plaque hemorrhage is T1 hyperintense, and we can look at these 3 sequences that are sensitive to the T1 shortening of intraplaque hemorrhage. Dr. Hideki Oto, when he's my postdoc, we collaborated with the excellent researchers at Vascular Imaging Lab, University of Washington, and showed that MP-RAGE was the best sequence to detect and to measure the size of hemorrhage, intraplaque hemorrhage, compared to histology. Okay, we can see intraplaque hemorrhage. What's the significance? And it's a predictor of future stroke, and it's in transition point from a stable to an unstable plaque. And I like how similar minds think the same. So Dr. Saba showed you this exact slide because it's such a powerful meta-analysis. If you haven't read it, definitely read JACC Cardiovascular Imaging from 2020. And whether the patient is symptomatic or asymptomatic, the presence of intraplaque hemorrhage portends a poor prognosis and increased risk of stroke. So I really strongly recommend, if you're not doing it already, add an MP-RAGE sequence into your routine protocol. Standard clinical sequence available from all manufacturers, 1.5 and 3T. You see you use your standard coil, no coil changes, and the SMRA hopes to have downloadable recommended protocols within a year or so to help ease that transition. And you can see with this patient, you can see the high signal intensity intraplaque hemorrhage on the MP-RAGE. Yes, you can see it on the time of flight, and you can even pick up these small areas on the contralateral side. Nugget 2, don't leave money on the table. If you start adding this, talk to your clinician. Nugget 1, make sure they understand the significance, and then include it in your report. You can easily make a template change that it's always routinely there. What's the impact of drug therapy? IPH, as we've already seen, is associated with future stroke, and it's also associated with plaque progression. And this has caused investigators to conclude that IPH likely overrides the beneficial effect of statin therapy. The significance of that is that clinicians probably need to do something other than give them statins, maybe PCSK9 inhibitors, maybe anti-diabetic drugs, maybe anti-inflammatory drugs. And again, multiple studies show this. Here you can see the high signal intensity, the intraplaque hemorrhage on time of flight. Again, don't leave money on the table. Nugget 2, and you can see how it progressed over 3 years despite the patient being on optimal medical therapy. We need to do something different. Patient is getting worse in front of our eyes. So this is how you use the information with your clinicians today. Patients may be at increased risk of future stroke or TIA if they have a persistent or enlarging necrotic core or IPH. These are things that you can see on your routine clinical stuff today. You can give your clinicians this information, and they're going to say, what do I do with that? And one of the things is they can consider intensifying medical therapy. Frequently, these patients also qualify for going for LDL goals of less than 55 milligrams per deciliter, adding PCSK9 inhibitors. And another option I've seen my clinicians use is they put them on optimal medical therapy, and if they have a subsequent event, they tell their patients, you may need an endarterectomy. So here's how they can use that information today. So nugget 1, ask your clinicians how they use plaque imaging. And in my few remaining minutes, I'd like to talk with you about this trial, IMPROVE. This is the multimodality trial that Dr. Saba was also mentioning. We can have multiple ways to look at risk of patients. This literally just dropped within the last month on the stroke as a preprint, and they showed it's a better way to stratify risk of future stroke, developed from 5 cohorts, 760 patients. This is all symptomatic carotid stenosis. So they used the presence of IPH and 4 other conventional parameters: the age of the patient, the sex, the percent stenosis, and the location of the stroke. Was it amaurosis, ocular, or hemispheric? And this improved risk stratification could help guide our next randomized clinical trial. This is kind of sine qua non of why we're here today. How do we change management? The beauties of this one, it's the first sufficiently powered model to predict ipsilateral stroke in patients on contemporary optimal medical therapy. In this group, there were 54 future strokes that happened. So that means you can look at 5 variables, more than we've ever had before in our models. And here's an example, a hypothetical, same patient, age and sex. This person has greater than 70%. This person has amaurosis. You go, he's symptomatic, he's male, he's over severe stenosis. Of course you want to take an endarterectomy. Yet this model predicts only a 4.2% risk of having a stroke over the next 3 years. This patient, less than 50%. We heard Dr. Saba telling us about embolic stroke, unknown source. This patient had TIA or stroke, but IPH. This patient has a much higher risk of having a stroke in the next 3 years. So you can see the potential, we're not there yet, but the potential of using the improved score. And of course, we can add PLAQUE RADS in here as well. This is driven by more than just IPH. The additional clinical factors help improve the discriminatory performance, and the study should be very stable. It needs to be externally validated. And so what the authors did is they took the median value as their first way to guess what would be a good threshold, and people with 9% or greater, they called high risk, and less than 9% intermediate risk, and you see this clear significant difference in cumulative ipsilateral stroke risk. So next steps, it needs to be externally validated. Those processes are in line. Decision analytic studies. When you want to set your threshold for the study, it's different if you're doing a surgical trial versus a medical. So that work is ongoing right now. And then you can see the power. We can finally be in a position to say plaque imaging should be front and center in a new randomized clinical trial with cost effectiveness. And we can test in symptomatic patients whether it leads to reduction in stroke and or lower cost. So what I was trying to do for you this morning is take you through CT and MR. Don't just measure stenosis. Report the presence of soft tissue plaque in focal hypointensity regions, PLAQUE RADS on IPH. Look for it on time of flight. Hopefully I've convinced you at MP RAGE. Again, PLAQUE RADS. We went through some of the new things that are coming down the pike, including photon counting, CT post-processing, and the improved score. And we've heard depictions of quantitative plaque imaging from our last presentation. And my nuggets for you, talk to your clinicians, don't leave money on the table. Thank you very much.
Great. Thank you, Dr. DeMarco, for the excellent talk and offering perspective really from the clinician's point of view, and love the nuggets. Thank you. We'd like to move on to the last speaker of this session, Dr. Chun Yuan. Dr. Yuan is a leading expert on MRI to visualize disease in the vascular system, and he has pioneered many MRI techniques for atherosclerosis imaging with extensive histological validation. He also developed analysis techniques and championed their standardization and translation. Dr. Yuan currently is the Parker Endowed Chair in Medical Imaging Research and Vice Chair for Research at Department of Radiology at the University of Utah. He also served as the Emeritus Professor at the University of Washington. My introduction of Dr. Chun Yuan is really redundant because I think everyone in this audience has read his papers, myself included. Dr. Yuan, the floor is yours.
Yeah, thank you. Can you see my?
Yeah, we can see your slides, but it's in presenter mode. As you can click on the top left, swipe displays.
Yeah, hold on. So this
is perfect.
Okay. Yeah, thanks.
Great.
Thanks for the nice introduction. My talk is supposed to be focused on image analysis, and by now you have seen many pictures of this carotid plaques or vascular imaging, for that matter. So from the analysis point of view, what is really interesting is the current clinical the parameter reporting from analysis is just a number, stenosis. But once you move this to vascular imaging, as shown in this picture, this becomes much more complicated. Is if you were to analyze vessel wall and also look at so-called plaque composition, it becomes pretty complicated. So one big question really is, what are you supposed to be reporting? So this work actually is done at in University of Washington almost 20 years ago now. That it's we developed a software called Cascade, and it's led by Bill Kerwin, who was the lead developer of this work. So the intention is, suppose you say you have multi-contrast images of the carotids, and assuming they are relatively cross-sectional, as shown in this panel, whether there is a software you can use to identify both the so-called lumen boundaries, outer boundaries, tissue composition, and how they distribute three-dimensionally, and whether this can actually be quantitative. So this software has been used in many clinical trials, including the current ongoing ones. So these are the major features of it. The first one, actually, we put a lot of attention to, in fact, is to identify lumen and outer boundaries, as shown here. And then the next step of it is to migrate this so-called lumen and outer wall segmentation into multi-contrast images. While doing this, we have to deal with issues of registration. So there's a built-in registration module around it. And then the third thing that we did, and this was 20 years ago, the machine learning was not performing well at that time at all. Rather than we developed something that is actually statistical based, a probability map of tissue composition, combining information from different contrast weighting. And at that time, we called this MAPS. So, and this is what MAPS is started. It's started from histology and then translated into multi-contrast MR images. And then the result is with this training, and we're able to get a reasonably clean map on MR images, and that actually is validated against histology. With this, that we're able to actually generate a so-called reporting system from Cascade that includes so-called thickness of the wall, and then highlighting where the lesion is, and the composition, and the volumes of different pieces. And this is what can be reported based on using this software called Cascade. Okay, realizing this is really just 20 years ago's work. And I think that I'd like to highlight some of the so-called recent development in this area. One thing is you have heard from all the previous speakers of the importance of IPH. So there are techniques now developed. It's geared for IPH detection in images, or hopefully in some sort of an automatic way. And you have also heard that our approach now, fundamentally from imaging's point of view, is quantitative. And that's driven for looking into T1 and T2 maps and hoping that will provide more sensitive information of tissue composition. In addition to that, I think one thing I'd like to talk a little bit, in fact, is the use of contrast, and especially using this so-called dynamic contrast to generate information that is related to plaque inflammation and neovasculatures. And lastly is that the old way of doing imaging is all 2D based. Now that things are very much focused into 3D, so the image analysis actually needs to also develop along that line of 3D analysis. So this is a drawing showing the so-called dynamic contrast. And then in addition to being able to acquire data in an efficient fashion, in temporal resolution wise, you also need to actually have a pretty established way of analyzing data. This basically is using this, labeled as using this padlock models. In this picture, basically you show that by acquiring images like this, you're able to you can analyze quantitative parameters such as VP and K-trans. Each one of this is related to so-called vascular permeability and quote-unquote inflammation, and also the amount of neovasculatures around in different areas. So I think that an interesting thing of this is that this model requires both acquire data of bright blood, so you can do this as arterial input function assessment. Also, you need black blood as such that you want to see vessel wall. So there are some clever ways of acquiring data in combination as such you can actually improve the acquisition and also temporal resolution as well as spatial resolution. So this particular study basically is done by Huijun Chen's group in Tsinghua, and it's doing that. And I don't think that we have enough time to explain this, but the intention is to improve both the temporal and spatial resolution, and therefore for the processing of the data. The base of the processing will still have to start from the point of identifying lumen boundaries, outer boundaries. Therefore, you can focus your analysis in the so-called vessel wall areas. You've also heard already in this plenty of discussions about quantitative imaging and the value of it. This work is done by the Cedars-Sinai group, is targeting dynamic contrast acquisition and using this so-called T1 mapping multitasking approach. Now moving on to a 3D image acquisition. I think this is an interesting area because there are plenty of 3D imaging sequences you can use for the carotid. This one is it's called 3D Merge that we developed, and it's Dr. Balu that he's in the audience today. He's the main developer of this sequence. The intention is it's a very fast acquisition of the carotid area. So you generate 3D isotropic acquisition, but with very short time that can give you very nice information about plaque burden and plaque distribution in this. And then the question is, if you have images like this, what you can also generate image processing that can go along with very fast processing to generate useful information. There are two examples of the work in that area. One is this work called Latte, and it's done by a PhD student, Li Chen, in our lab at the time. The intention is, suppose you can get this a 3D data set. This algorithm should actually go in, automatically identify where the carotids are, and also label them as normal and diseased automatically without doing any other quantitation of it. So it's a very easy screening tool. And the intention is, suppose you do this, tons of this 3D merge imaging, you may actually be able to use softwares like this to filter out patients who may have problem or needs additional analysis. And recently, this Dr. Hashmi Daza from University of Utah further extended that into so-called, these are both AI-based techniques. The intention in this case is this not only is able to visualize lesions, but is able to actually do quantitative measurements automatically. So it requires identifying where the lead arteries are and also segmenting both lumen and outward boundaries using different neural network approach. And from there, you can actually generate a very nice distribution of where lesions are. As shown in this picture, that this is a way of reporting data centered at the bifurcation areas shown here. Then you can report this based on visual things of where the lesion is or lumen outward boundaries. You can also generate a so-called quantitative measurements from different locations of the thickness, plaque volume, and so on, in addition to looking into stenosis itself. So moving on to this so-called IPH area, there's I think that in general, if you want to have a good way to look at IPH, you should also, it needs to be heavily T1 weighted. So this is an imaging sequence that we developed called SNAP. It's heavily T1 weighted, has very good flow suppression of lumen. So you can have a decent angiographic map of the lumen in addition to have a nice view of where the lesion is and also whether they have any intraplaque hemorrhage in those locations. So the question is, if you have images like this, whether you can also process data such you can get this so-called intraplaque hemorrhage information in some automatic way. That Jin Liu, who also was a PhD student at our lab, and this was reported in 2019, approached this through this so-called thresholding-based techniques. So the idea is, as long as you can identify where the carotids, or especially the bifurcation is, you don't really need to have a so-called segmentation of lumen outward boundaries. If you are able to threshold the data, you should actually be able to report whether there's IPH. If you see them, you can report their volumes and so on. So it's a simple approach, and then it's based on heavily driven, based on signal intensity. Recent work is done by Ying Guo, who's a current PhD student in University of Washington, is expanding this into a so-called machine learning driven, a neural network approach in identifying IPH. So the idea is you should actually be able to automatically detect where the arteries are. And then using this 2D UNet approach, that you can actually segment out IPH, and those also is independent of looking at lumen and outward boundaries. So you're just focusing on IPH alone. And then you can actually report those results. And there are some sort of accuracy reports based on either one of this. And I think that in addition to that, as partners, SMRA and also partners with Mackay actually has done a grand challenge in 2022, focusing on carotid vessel imaging and automatic analysis. In that session, I think that there were several groups were presented of different approaches how to segment carotid vessel imaging. So in other words, that this presentation is sort of focusing on some of the sample work. It's not intended to have a thorough reference literature search to include many other people's work. But the intention is the same, is that to show where the trends of this work has been. And then you have heard this from Dr. Saba already, this PLAQUE RADS. I think this actually, from an image processing point of view, poses another question is, how do we incorporate this part into an image analysis? Because what I showed off, those are 3D approach. On one side, one is able to identify lumen and outward boundaries, therefore plaque burden. The other one is identifying IPH. But in truth, if we want to produce a so-called decent PLAQUE RADS score based on MR images, we still need some sort of a combination of multi-contrast 3D imaging. And then we need to combine those approaches into one package to do this, and hopefully simple. That I think is still to be seen. And I like to summarize this by saying that if you think about where we are now and the challenges we're facing, I think on one side is we are now fundamentally dealing with a 3D multi-contrast acquisition. And many of this acquisition is not necessarily acquired from axial angles, rather than it may be coronal, sagittal. And then reformation, thinking about how to generate true cross-sectional view images along the artery itself is not a subtle issue, rather than it actually can get complicated at some place. The second one is this type of analysis definitely should actually be extended into other vascular beds. For example, intracranial, extracranial, they're just neighbors, that we should actually be able to somehow extend this or combining them in effective way. I think that invariably, it doesn't matter which technique you choose, you always have to deal with artifacts and signal contrast issues. And even the lumen boundary, the outward boundaries detection sometimes can be highly challenged. And lumen boundaries, if you don't have a good, decent flow suppression, it can be really confusing. And for people with so-called untrained eyes, look at those, they may look like just like a plaque. So it's a problem, I think, remain to be dealt with, both from the acquisition point of view and also from a post-processing point of view. And another one I think it's quite interesting is whether we can extend this type of analysis into multi-time point data. And further, whether we can actually, if we started going T1, T2 mapping and other things that is related to signal intensity, how do we actually normalize this in some fashion as such that we can really do it across different platforms and to get quantified or unified results? I'd like to stop there and thank you for your attention.
Thank you, Dr. Yuan, for excellent talk to highlight the need and the importance of post-processing segmentation. I think now it's good time to transition into question and answers. We're running a little bit behind, but hopefully we have a little bit more time to discuss. I can already see some questions popping up on the chat, and if you have additional questions, feel free to type into it, and also, or you can raise your hand, and I can unmute you to ask the questions. But looking at the chat, I think there's a question from Isabel Casada. I think this question is direct to Xihai. I think I'll try to paraphrase, but mainly, how do you think we can obtain co-registered black blood images? Is the current simple approach sufficient to differentiate components of plaque and vessel wall? Xihai, are you?
Yeah. The question for me?
Yes.
Yeah, for this co-registration for the black blood and with the quantitative map, am I my understanding is that correct?
Yeah, so I think the question is mainly about whether the black blood images from simple, for example, can be sufficient for delineate different plaque components with the concerns regarding co-registration.
I don't think it's good enough, because currently I think for the simple sequence is that that's only T1 map. We can only generate T1 map. The T1 map, I think, is really challenging to differentiate all the plaque components, especially for the classification. You know, for the classification on T1 mapping is almost overfitting, so we cannot get a correct T1 value for the classification. So for the other components, we found that we do have the confidence to identify intraplaque hemorrhage, but rather than the other plaque components like lipid-rich necrotic core, because there is an overlap between IPH and lipid-rich necrotic core in the T1 values, and there is a large range of standard deviation, because even we cannot find a larger intraplaque hemorrhage within lipid core, but for some lipid cores, they do have some tiny IPH. So the T1 values will have a large range. So I think we cannot use one mapping to do all the things. And for the other question is how to registrate or make registration. I think this is a good question, because if we do not have a good registration, so we cannot get a very accurate quantification. So I think currently I think currently we do need to develop some post-processing imaging tool to analyze the quantitative imaging images. For example, how to efficiently analyze T1 mapping, T2 mapping, or T1 and T2 mapping. So that's the multi-parametric imaging techniques. I think currently there is no good post-processing tool. This is I think this is a very good future research direction.
Okay, great. Thank you, Xihai. And also, Isabel, you raised your hand, so I unmuted you. Feel free to comment or if you like.
Yeah.
Isabel, can you hear? I don't think I can hear. In the interest of time, maybe I'll go to the next question, which is from Dr. Drew Brett. I think Drew asked whether the information from MRA is great, but from a surgeon's perspective, the barrier of implementation, such as complex interpretation and post-processing, may pose a barrier to use clinically. How would someone address that issues? I think it ties to the Dr. Chun Yuan's talk on whether the segmentation and post-processing can be automated to make that process. But I wonder whether there's any other perspective from the panel. Maybe Dr. DeMarco? How to make it feasible for clinical implementation?
Sure. Well, I'll comment and also ask Luca to comment, because he wrote some really good responses in there as well. And Drew, if you're able to actually respond, it would be very helpful as well, because you're exactly the audience that we want to reach out to. We want to get beyond MR scientists and get to our clinicians who are using it. So you mentioned you're a vascular surgery resident, and so congratulations for being here. And I'd like to, and we'll talk offline some more about what your experience is. But in general, that's how I tried. Your questions are what I was trying to address with my portion of the presentation. You heard some fantastic science. This field is continually evolving and getting better. But what can we do today, right now? And so I think the general answer to your question is, I know at least the vascular surgeons at Walter Reed and Bethesda make predominant use of duplex ultrasound. It's the minority, probably 10, maybe 20% of the patients that go on to get cross-sectional imaging, and virtually all of that is with CT. So if that's similar to your practice, that's one question I'd like to understand. But with CT, as I mentioned, it's relatively straightforward to find large necrotic cores, which are worrisome. And then when you have new or increasing size of necrotic core, or if they've been on standard therapy that you're comfortable with, that it's optimal, and it's still there, that might be a time to change it. And that's when I would get an MR. And then the MR, we can do it without contrast, And there's every time I've introduced the MP-RAGE sequence, it's been a real hit in the clinical practice. The clinical neuroradiologists love it, and it's very simple to interpret, and I think straightforward what I showed you. So I don't know if that answers your questions, but that's how I would implement it today while we're waiting for all of these other excellent, more quantitative measurements. And Luca, Chun, if you guys have other thoughts.
Thank you, Kevin. And Dr. Saba, would you like to add anything to the comments?
Well, I agree with Kevin. What I think is that use is linked to the value of the information. If we produce an information of value that the surgeons can use to select an approach, they can accept also to use maybe a complex method. But we should demonstrate that the information changed something. So I think it's a bilateral approach. We should demonstrate that we produce useful information, and we should explain to our colleagues what is the value of this information, basically.
Great. Thank you, Dr. Saba. Can move on maybe to the next question posted on the chat by Heinrich Ralphs regarding the SNAP technique. Perhaps this is direct to Dr. Chun Yuan. So is SNAP a quantitative measurement, or why is the thresholding for hemorrhage segmentation working otherwise? And because based on, I think, his experience, they see a varying intensities between subjects and scanners. Perhaps you could shed some light on that question.
Yeah, thanks. I think that's a very, very important question, in fact. For SNAP is not a quantitative technique. Rather than it's just heavily T1 weighted. And then it's more details of it. It's a phase-sensitive reconstruction, therefore, you can actually have a better separation of lumen and wall from that sequence. So that's, I think, the advantage of it is comparing to MP-RAGE. The other thing is about thresholding. Anytime when you do thresholding, the absolute signal intensity itself is almost completely meaningless in this case. What is meaningful, however, is this contrast to noise ratio where you establish a reference point. In this case, in the carotids, we have actually used this muscle next to the carotids. It has a very long name that I would just use it as SCM. I think it's most of the physicians pass their test by say the name correctly. I can, so I'm not a physician for that matter. But we use that as the reference standard, meaning all other signals are normalized against that from different. So the intention is, it doesn't matter where the images, how the images are acquired at different scanners in different places. But if you use that as a reference standard, thresholding should work. That's just in ideal situation. I think another factor to consider, in fact, is in a carotid area that people have been using this carotid coil. The carotid coil's position may also heavily impact the signal in this. So that is a concern. So in other words, that if you truly have, I think in an ideal world, if you have a really nice T1 mapping technique, I think that may actually be better. But I think that, as you've heard, I think it's a nice idea, but at this moment it's still sort of suffering from overall signal to noise and other issues that making the measurement itself, it's remains to be challenging.
Yeah, I agree. I think the T1 mapping and quantitative imaging does have the potential to deliver, because in theory, this can be portable between different approaches, shouldn't be affected by coil. It's essentially a harmonizing way to method for different imaging intensities. But yeah, we still have some way to go. So I think I have another comment from the chat, which is from Linda Billos who's a surgeon in Sweden, and I think she shared the same concerns regarding the question we talked about. The image techniques are complicated, so whether whether it can be applied to clinicians is a question mark, and it's something we need to address as a field. I see Monica still has a raised hand. Monica, Isabel, do you still want to comment? If so, maybe you can unmute.
And actually, I went ahead and responded to the question from Linda. And the basic comments I would make here, if our clinicians ask us for something, that usually drives radiology to do it. So if you start looking at the low attenuation plaque on CT, if you start looking for the high intensity on the 3D time of flight in the plaque, that will drive your neuroradiologist to start delivering it. So you may have to be the driving force at your institution, and it's nothing. It's what they do standardly. So there's nothing else for them to do other than do what they do standardly. And as I mentioned, nugget 2, don't leave money on the table.
So maybe I can ask one more question. So for our experts, so in your opinion, what is the minimum scan time you think enough to provide the information and also get a clinical practice accepted?
Did you mean maximum scan time allowed?
Minimum, sorry.
Minimum, okay.
Well, I think that there is a paper from Alan Moody that said that the time of flight it's enough because we can obtain information in intraplaque hemorrhage. So the basic approach is very simple. It's a matter of 10 minutes. Maybe it's not enough, but it's a good starting point in my opinion.
Yeah, thank you.
So I can add something. Actually, in clinical settings, once the imaging sequence, the scan time larger than 10 minutes is really hard to use this generally. So I think if we want maximize the imaging protocol, especially for the scan time, I think we should reduce the scan time within 10 minutes. So either one imaging sequence, like a hybrid imaging sequence, you can scan one sequence to get multi-contrast images, or you can scan 2 imaging sequences. But I think it depends on the clinical needs. Like if we use this scan to screen some patients with or without vulnerable plaques, I think usually just one imaging sequence like SNAP can be good enough, because this hybrid imaging sequence can generate both MRA, non-cancer MRA, and heavily T1 weighted images. So that's good enough. But this is just for screening. Yeah.
Okay, great. Thanks for the comment, Xihai. I think we addressed all the questions. If there's no more questions, I think I would like to again thank all the speakers today for excellent talks, and also I'd like to take the chance to thank the organizers, Dr. Niranjan Balu and Dr. Mahmoud Musabasa, for lining up such an all-star line of speakers. And again, thank you all for attending this webinar. I hope to see you all next time.
Thank
Thanks,
you.
everyone.
Thank you. Thank you. Bye.
Thank you. Bye.
Bye-bye.